Management of ocular surface squamous neoplasia in association with fungal keratitis in an HIV-positive individual. I have no financial disclosures or conflicts of interest. A 42-year-old male presented to us with the chief complaints of a whitish growth over the cornea of his left eye since the past 4 months. The lesion had started off as a small painless papule at the limbus and then gradually progressed over 3 months to encroach the cornea. He had initially taken over-the-counter topical steroids for 3 months and had reported to us only when the lesion had become significantly painful with a decrease in his visual acuity. His uncorrected distant visual acuity at presentation was 20 by 20 in the right eye, but only 20 by 600 in the left eye. Examination of the left eye on slit lamp revealed a mixed leukoplaque lesion of size 4.5 by 6.5 millimeters overlying the cornea, along with a papillomatous lesion of 4 by 14 millimeters overlying the inferior and temporal bulbar conjunctiva with overhanging keratin straddling the nasal and the inferonasal limbus. Multiple dilated and tortuous feeder vessels could also be seen. A diagnosis of OSSN was arrived at. However, along with this lesion, there was also an ulcerative lesion with 4 by 3.5 millimeter infiltrate involving more than 2/3 corneal thickness with feathery edges overlying the visual axis. On gross slit lamp examination, the phonesis were unaffected. There was no enlargement of the preauricular or submandibular lymph nodes, and the inferior and temporal bulbar papillomatous lesions took rose Bengal stain, highlighting the extent of involvement. Because of such an extensive lesion in a young male, he was screened for HIV 1 and 2 and was found to be positive. Corneal scraping also revealed separate hyaline fungal filaments. To treat the fungal ulcer, he was started on hourly natamycin along with homatropine 2% thrice a day. After obtaining a normal LFT, he was also started on oral ketoconazole. He was counseled about his immunodeficiency and started on heart therapy after checking his CD4 counts. To manage the OSSN, after 1 month of treatment with antifungals, his ulcer had resolved. The corneal scar had become evident. After performing an ASOCT, the OSSN was seen to be confined to the epithelial layer and he was started on topical interferons 4 times a day. After 3 months of interferon, the lesions across the bulbar conjunctiva had resolved completely, leaving behind only stippled pigmentation. However, the lesions over the cornea and the limbus were still present. At 5 months, it could be seen that even these lesions had resolved completely. He was continued for interferon for 1 more month, and to this date, he has completed 2 years of follow-up without any recurrence. Coming to a discussion, a case series of 60 patients with concurrent OSSN found that they were positive for HIV in 38 to 41% patients. However, 70% of them were unaware of their HIV positive status. As we know, there are several risk factors for fungal keratitis. Our patient had risk factors like previous use of topical steroids, a poor ocular surface, and HIV positive status. In this case, the tear film distribution abnormality because of the OSSN could have led to Delin formation. Also, non-resolution of the OSSN could have led to epithelial breakdown and ulcer formation, which could have become secondarily infected with fungi. Literature also reports that there was one case which could not be managed medically and extended enucleation had to be performed for that particular case. However, in this case, the patient had a pre-existing fungal keratitis. OSSN had developed later on. To conclude, immunodeficiency in HIV infection predisposes an individual to development of OSSN as well as infective keratitis. Therefore, all patients with OSSN should be screened for HIV. The epithelial compromise caused by both pathologies makes management difficult. However, sequential management with topical immunomodulators continued for 1 to 3 months beyond clinical resolution of the OSSN is effective. These are my references. Thank you.
Thank you, Saranya, for that wonderful presentation. And if there are any questions for Dr. Saranya? Okay, thank you.
So the next presenter is Dr. Sahai, and she's going to present a case on hepatitis B with geographic ulcer. Dr. Pranita Sahai.
Okay, good afternoon everyone. I'm Dr. Pranita Sai and I'll be presenting a case of demystifying a case of acute red eye. Acute red eye or conjunctivitis is something that we commonly deal in our day-to-day practice. So this was a 47-year-old male who complained of redness, watering in the right eye for last 20 days and reported worsening of symptoms with the ongoing therapy. He was diagnosed as a case of acute conjunctivitis by the primary physician, and view of severe congestion started him on FMLT 3 times a day with lubricants for a week. However, in view of persisting redness and discharge by the patient, he was shifted to Vigadexa 8 times per day in tapering dose by the primary treating physician. He did not have any systemic history or any drug allergies. Systemic examination was well within normal limits. Vision in the affected eye was 612 and the other eye was normal 66. IOP was normal. This is how the right eye looked. There was diffuse conjunctival congestion. Follicles were present. The cornea looked clear. No anterior chamber reaction. Fundus was normal and normal corneal sensations. However, there were some white suspicious areas that we could see on the conjunctiva which appeared as necrotic patches. Similar suspicious lesion was seen at the superior limbus, which on further fluorescent staining showed geographic pattern of conjunctival ulceration or epithelial defect that took up the fluorescent stain. Similarly, the superior limbus also took up a fluorescent stain, and on further rose Bengal staining, we could see fine dendritic lesions appearing at the limbus. And similar lesion was noted adjacent to it at the 12 o'clock position. Hence, we made a diagnosis of right eye viral keratoconjunctivitis with geographic conjunctival and dendritic corneal ulcers, the left eye being normal. The patient was started on topical antibiotic, lubricant, and cycloplegic, along with topical antiviral therapy, acyclovir ointment 3% 5 times a day, and was given some anti-inflammatory for pain relief. This is the day 1 picture. There was decrease in congestion. Also, the conjunctival epithelial defect started to decrease. The corneal defect had almost resolved. And this is the day 3 picture, further showing complete resolution of the conjunctival and corneal lesions. Day 14, now the patient is only on lubricant, and day 28, complete resolution of the conjunctival and corneal lesions. The visual acuity was 6.6, IOP was 14, and the tear film parameters were also within normal limits. Hence, to conclude, this was a case of acute red eye diagnosed as viral conjunctivitis, treated with steroids, who developed conjunctival ulcers and corneal dendrites and resolved with antiviral therapy. So now we need to understand that acute infectious conjunctivitis is mostly viral, of which adenoviral is the most common cause. Treatment is basically with lubricants and symptomatic support. Povidone iodine and steroids have some role, and use of antibiotic is for the doctor's doctor's satisfaction, basically no role in treatment of conjunctivitis. Now, the use of steroids in conjunctivitis should be very cautious. Indications are limited to pseudomembranes and present of subepithelial infiltrates with photophobia and diminution of vision. Adverse effects can lead to prolonged viral shedding, increased IOP, and sometimes exacerbation of the herpetic viral infections in the form of keratitis. So it is important to differentiate acute conjunctivitis adenoviral versus herpetic. While the adenoviral is more common, herpetic infections can also present. They are mostly unilateral infections and worsen with steroids, and also the nummular infiltrates in herpetic infections appear to be larger in size and variable in appearance. That is how we can clinically, to a certain extent, differentiate herpetic from adenoviral conjunctivitis. So every conjunctivitis does not require microbiological testing, but definitely if it's a neonatal conjunctivitis, a recurrent one, recalcitrant to therapy, or severe discharge, or suspicion of gonococcus, then go for microbiological testing. And this is a literature review that is showing various appearances of viral conjunctivitis with geographic ulcers. So causes for which can be both infective as well as drug-induced conjunctival geographic ulcers have also been reported. The drugs reported to be involved are nicorandil and PST injections. Even Crohn's disease, Behçet's disease, and Wegener's have been reported to be associated with conjunctival geographic ulcers, which need to be ruled out. So the learning points are that ocular surface staining can highlight subtle findings. Rose Bengal can be extremely useful in herpetic ocular surface infections. Herpetic infections can cause geographic conjunctival ulcers. Hence, we need to have a cautious use of steroids in conjunctivitis, and timely use of microbiological tests in non-resolving conjunctivitis can be beneficial for patients. Thank you.
Hello everyone, I'm Dr. Ashish Majumdar here to present a rare case of brittle cornea syndrome, 1 in a million case. A 9-year-old female patient has came with a chief complaint of gradual dimness of vision in both eyes from the childhood with frequent change in spectacle. She has also complained with photophobia, blurring and ghosting of the object. Uncorrected visual acuity of right eye is finger counting 1 feet, and in left eye it is finger counting 2 feet, whereas best corrected visual acuity is 660 in both eye. On slit lamp examination, we have seen blue sclera, horizontal nystagmus in both eye, thinning of the cornea, central corneal opacity, and Munson sign was positive. She has also shown vox stria, prominent corneal nerve, and Fleischer ring in both eye. Though the fundus examination was a bit blurry image we got due to nystagmus and astigmatism, but here we can see the tessellated fundus, tilted disc, and myopic crescent in both eye, which is suggestive of pathological myopia. The tomography has shown that the thinnest local point of the right eye, the pachymetry was 384 micron, and in left eye is 373 micron. After ophthalmic examination, her auditory system examination shows the moderate to severe sensorineural deafness with sloping pure tone audiogram. On musculoskeletal examinations, she shows long, slender extremities, hallus valgus, loose skin and hyperextensibility of small joints suggestive of Ehlers-Danlos syndrome. She has also presented with umbilical hernia of 21 into 16 millimeter gap in anterior abdominal wall with mild tricuspid regurgitation, and she also had a history of convulsion in childhood and history of delayed motor development. So and she has a history of consanguineous marriage between her mother and father. So from here, the provisional diagnosis is come to a rare case of brittle cornea syndrome. Now we needed to do a confirmatory test. For that, we have done one genetic sequencing test, which shows homozygous autosomal recessive pathogenic mutation in PRDM5 gene, which is suggestive of brittle cornea syndrome type 2. For this patient, as she does not have any kind of rupture or very pathological any problem, so we plan to go for medical management and visual rehabilitation. For that, we had done refraction and glasses has been prescribed. Protective polycarbonate glass and contact sports has been avoided. According to Bright et al., it has been shown that there are two kinds of brittle cornea syndrome. One is BCS1 and BCS2. In brittle cornea syndrome 1, there is zinc finger mutation, and in BCS2, there is PRDM5 mutation. But in BCS2, there are various variations. This is variant number 1, because she has homozygous mutation with no corneal rupture. There is myopia, keratoconus, and blue sclera. She also have abnormal scarring of cornea. She had small joint hypermobility. She had hernia. She had deafness, and her CCT in both eye was less than 400 micron. So my question to the chairpersons are, as this patient is gradually thinning her corneal thickness, so I am very much scared that she might have a corneal rupture in very recent days. Though there are various literature, those who have shown that there are suturing with 11O nylon sutures and or like lamellar keratoplasty. What should you suggest to do in this case? Thank you.
I would wait and watch, and if needed, I'll go for a surgical treatment.
So what surgery do you prefer, sir, in this case?
There's a perforation or an inverting perforation or an extreme thinning, I would prefer keratoplasty.
Is there any special care we should take for this case?
No, but pediatric keratoplasties are always special, we need to take utmost care. Rejection component is low, and they are special cases, but risk and the benefit, I would definitely watch, and if there is a greater risk of perforations or an actual perforation, I'll definitely go for a surgical plan.
Thank
Sir,
you, sir.
any role that you think for corneal cross-linking in these patients?
The picture what you showed,
That is showing already scarring. In this case, yeah, in this case it would probably not be the case. But in case there's no scarring, then would you consider for cross-linking?
cross-linking is a good option for all ectasias. Cross-linking should be the primary option, but
In this
certain
case,
amount of
obviously.
thinning and
Yeah.
scarring, I wouldn't think about
So
cross-linking.
just an experience, just last month I had a case of brittle cornea syndrome referred from outside, 12-year-old kid, both eye twice operated, graft, one eye in phthisis, other eye also a failed graft with RD. So obviously the prognosis with these patients is not really good. Even with the best of efforts, a lot of patients do end up being blind. So we did a K-Pro VR and a keratoplasty for that patient, did rehabilitate, but obviously the life of these kids are really compromised.
So what K-Pro you have tried?
We
for
did a
this?
temporary K-Pro with VR and an optical keratoplasty in that patient.
Thank you. Thank you.
Very challenging and interesting sort of a syndromic case that you brought out. So as Pranita also mentioned that these children most of the time realize, the family realizes there's a problem and they come in with some minor injury. So there's a perforation after minor injury. And when you're dealing with the case, that's when you realize or you've seen the patient preoperatively. Because it's difficult to examine the eye, but you have to, and this is very well sort of physical, the phenotype was very typical. Sometimes you may have a little variation in that. So you have to watch out for a child who has such a bad blow perforation after trivial trauma. So like we pointed out. So this child is always at risk, even a very forceful Valsalva maneuver or anything of that sort. Very minor injury. So we had a patient who, the mother was combing the hair of the child, just combing the hair with a comb, and that's what injured the eye. So even very trivial injury can damage the eye and be large perforation. So again, just like you said, for this particular case, because the pachymetry, as per what you saw,
Yes.
is not as thin. But
Yes.
if it's thinner than this, then and you know you have to take the risk and benefit. So if you leave the child alone, then it's likely to perforate, and then you have to do an emergency situation kind of. So if at least for one eye, if you want to visually rehabilitate, what we do is like an epikeratoplasty with a sort of a, you can't even do much of peripheral tucking because even the sclera is not healthy with the little cornea, so it's difficult to suture. But saving the stem cells, just a little bit of peripheral dissection and tucking in the flange in there, and that can work. We've had success over there, but again, it has its multiple problems, as we said, including glaucoma, rejection, epithelial ingrowth, and so on.
Ma'am, will tuck-in lamellar keratoplasty will help in this case?
Maybe.
So it's again difficult to tuck it in because of the sclera also being abnormal. So we have to see case to case whether it is possible or not. The reason to tuck it in is because of being such a large keratoplasty, you want to protect the stem cells, you don't want to excise or suture on top of that, and you want to stabilize the graft that you want to put in there.
Thank you.
Optical keratoplasty means it's too much of the opacity is there, scarring is there, and so much of thinning is there. So we can wait and watch, as sir has said, by keeping the BCL for some time, and then optical keratoplasty is the choice.
Thank you, sir.
Yeah.
So I had a case fairly recently, maybe 6 months ago, where the child came similar with trauma, and the parents just didn't realize that the child has so many other problems, including also had systemic problem, like your case had cardiac issues. So did our child, and so I had to take a 14 millimeter graft because there was a complete perforation. In fact, the perforation was literally at the limbus. It was running about 270 degrees. From one end, it had just ripped across, going to the other end. So I actually took a smaller size graft, and when I was suturing, I realized that this is not going to work. So I had to literally just sacrifice the tissue and again remeasure and take a bigger graft. And it took me 2 or 3 hours to finish that case. So that child, because we used a very good optical quality tissue, so the child is doing okay. But as Dr. Lionel Raj mentioned, that it's a very tough, challenging situation for pediatric patients.
Thank you.
So thank you for that. We'll go with the next presenter, that's Dr. Neha Kumari. And she has a rare case of PUK. Is Ankita here in the audience? And Dr. Rakhi is here, I saw you. Dr. Surbi is also here. Dr. Surbi is here? Okay. Any other presenters we are missing out? Okay. So we have Priyanka and one more presenter. All right. Have you loaded your presentations? Because he doesn't seem to have them. Yes, over to you, Neha.
Thank you. Good afternoon, everyone. Here I am presenting a case of bilateral peripheral ulcerative keratitis. I have no financial interest. Case history: a 60-year-old male patient, former occupation, came to IOPD with complaint of foreign body sensation 1 month, redness, eye pain, and photophobia since 20 days. History of presenting illness: the patient was apparently well 1 month back, then he started experiencing foreign body sensation in left eye following an injury with tree branch. And for the last 20 days, he complained of redness, eye pain, photophobia from both the eye. There is no significant past ocular and medical history, and family history, no significant ocular disease. In general examination, findings are all well within the normal limit. Patient was well oriented to time, place, and person. In ocular examination, the patient's best corrected visual acuity in right eye is 6/24, and in left eye is 6/36. Pupils are central, round, and reactive in both eyes. Extraocular movement and IOP are within normal limit. Slit lamp examination. This is the slit lamp photograph of right eye in diffuse light illumination. All findings are within normal limit, except in peripheral cornea, there is 4 o'clock to 6 o'clock position, there is a crescent-shaped ulceration present, although central cornea is clear. This is the slit lamp photograph of left eye in diffuse light illumination. Here conjunctival congestion as well as circumciliary congestion present. Central cornea is clear, but at 4 o'clock to 10 o'clock position in peripheral cornea, there is crescent-shaped ulceration present with corneal thinning also present. Coming to the provisional diagnosis, this is the case of bilateral peripheral ulcerative keratitis with corneal thinning in left eye. In diagnostic workup, first of all, comprehensive systemic review to rule out systemic disease associated with PUK. The 3 most important diseases are rheumatoid arthritis, Wegener's granulomatosis, and SLE. A complete ophthalmic examination to exclude local pathology. Corneal scraping was done and subject to gram mount, gram staining, KOH mount, and microbiological examination. In this particular case, blood culture shows staph growth. In lab investigation, complete hemogram, ESR, CRP, CNK, and PNK or urine analysis was done. Blood investigation came negative. Patient was advised for rheumatologist clearance for systemic immunotherapy. Differential diagnosis includes Murren's ulcer, Tadian's marginal degeneration, pellucid marginal degeneration, and keratoconjunctivitis sicca. For treatment, patient was started with oral prednisolone 1 mg per kg body weight, tablet doxycycline 100 mg BD, eye drop moxifloxacin, lotepred 4 times a day, eye drop cyclosporin 0.5% BD, and eye lubricant and cycloplegics are also added. This is the slit lamp photograph of left eye after follow-up of after 3 months of regular follow-up. In this photograph, we can see that inflammation was under control and ulcer is in healing stage. So PUK is a rare inflammatory condition of eye which affects the juxtalimbal cornea, and it classically presents with the ulceration of peripheral cornea, epithelial defect, and stromal lysis. Can be the first presenting feature of a life-threatening systemic disease, and it can be associated with autoimmune disease, among which 50% is associated with collagen vascular disease. Coming to the pathophysiology, any inflammatory stimulus in peripheral cornea results in immune complex deposition in limbal vessels, which causes complement activation and which leads to chemotaxis of neutrophils and macrophages. These inflammatory mediators causes release of collagens, metallic metalloproteinases from keratocytes, which causes destruction of stromal causes and corneal ulceration and thinning. So to conclude, one second. Prompt management of PUK is to reduce mortality and morbidity, and primary goal is to promote epithelial healing, stop stromal lysis by controlling inflammation, and prevent the superinfection. Thank you.
Thank you, Neha. That was a well-presented case. So we'll move on to the next presenter, Dr. Priyanka Bharti. In the meanwhile, we're having help with the audio-visual.
We can take some comments for Neha's case. So the last few slides we couldn't see, but
Yeah.
we got most of the
Yes.
We could see is bilateral PUK, and you managed it with steroids. That's how we generally do. And let me.
What about the cyclosporine that you have used? It is back-free, preservative-free? Okay, now it is available. Cyclase from Intas, that is preservative-free.
what's the percentage that you use?
0.05.
0.5% she is saying. 0.05, okay, okay.
That was a good case, Neha. I think that it was a very, it was not as severe as some of the cases that we see with PUK. So that way, right, right. So in PUK, when you have immune mediated, meaning there's no infection, it's not a pseudo PUK, then there are only two kind of entities. One is if you have Moran's ulcer, which has its own classical pencil overhang edge, etc., etc. And the second is you have sort of a non-specific, but maybe immune mediated. So yours was in the second stage. This one, the second kind, this usually has a better prognosis. So as you treated very correctly, you examined and you did some investigation for the patient, and then you treated the patient with steroids, and the condition resolved. So let's just keep our fingers crossed that the patient doesn't keep coming back to you. Then there are many other conditions, which not many other, but a few other, which look like PUK. So you can have marginal keratitis due to various other causes, staph, lid issue, or you can have due to herpes and so on. So that you try to rule out. But my point about the entire way which most of the ophthalmologists, including cornea specialists, look at PUK is that the minute the patient comes, you do a workup, a systemic workup. Systemic workup has no role, except if you see a kind of a PUK which matches a pattern of rheumatological disease. There are just basically about two rheumatological diseases that can have PUK. One is rheumatoid arthritis. The other one is GPA or vaginal dermatitis. Yeah. And that patient could come to us first, frankly speaking, without much of systemic problems. So apart from that, if you do a lot of investigations, you'll get something positive. Then you'll start chasing that something positive. Let's say Mantel's test and things like that. So what I would suggest to the group is not to investigate the patient too much, because there aren't any biomarkers. There aren't any absolute biomarkers. If this is positive, then this patient has this disease. But after a point, stop focusing on investigation and then you treat these patients as you correctly do.
And long follow-up is required in such, because recurrence can be there.
And is Dr. Saranya here? Dr. Saranya, I really appreciate, because immunocompromised, bad ocular surface.
We are going back to discussing your case,
which
we were supposed to do in the end, but
since all these and also fungus in an immunocompromised and damaged ocular surface, very tough to handle, but the results were very good. So I appreciate. But then she discussed nearly 30 to 40% of OSSN case would have HIV.
That's
HIV.
no longer-
That's up. Do you have any data to support this?
You can just speak loudly.
It was found in a case series where 60 patients had been examined. 60 patients with OSS and respiratory HIV. And out of that, out of 60 people, 40% were patients who found positive.
So HIV as a disease has gone down a lot, luckily, and also OSSN is much more prevalent than we think it is, and it's not associated only with immunocompromised individuals. Even immunocompetent individuals develop OSS. So that's an old data. If you read papers which have large series now of late, there is a prevalence of some immunocompromised condition and other virus association, systemic association, but not as much as you pointed out. So no longer is that entity that
It's
is
almost
strong.
1 out of 3 or 1 out of 2, what you say.
Yeah,
2 cases of OSS and 1 is HIV positive.
that is the older literature. So do you know Murphy's law? It says that if something has to go wrong, it will go wrong. And under Murphy's law, there are 4 laws. One of it says that if something has to go wrong, everything possible will go wrong with it. So this reminded me of that. So the patient had 2 disease in the eye and then also a systemic disease. So sheer bad luck, but it was managed well.
And Dr. Pranitha, about the new terminology of conjunctival geographic, it makes sense, but there are so many other differential entities.
Yes, sir.
It need not be herpetic keratitis. But in your case, did you do a PCR or?
So we did not do, I actually planned to do a PCR testing, but the dramatic response it showed within 1 day of starting antivirals and complete resolution by day 3. So I did not think it was necessary to go on to
So it's
PCR
just a
testing.
presumed diagnosis.
Yes,
I
it's a
wouldn't tell
presumed
it's.
diagnosis.
Patient responded instantaneously, then you started the antiviral.
No, sir, we started antiviral day 1. There were resolution of symptoms, that
Okay.
is, it had started to go down almost 30-40% decrease in the epi defect, and by day 3, 72 hours, the conjunctival ulcers and the small dendrites, they also resolved.
Okay.
So sensations, the patient was already so photophobic and watering and red. We did check the sensations, it appeared to be normal. It was not reduced. But yeah, it. But in all patients, we cannot have reduced sensations also.
So, I think that Pranitha made a very convincing case for herpetic disease, and we have seen similar such cases. Although it's little hard to prove, but only when you had corneal manifestation as well, so
Yes.
that made it very clear.
Yes, ma'am.
And in those patients we didn't start therapy till we saw the corneal lesions.
Yes,
And once you start corneal lesions, you have dramatic improvement.
yes.
So if it's only conjunctival, you may not have any change in the corneal sensation. Only when it's corneal involvement, then you have a change, decrease.
Also, PCR is not available at every
Everywhere.
place.
We tried to find a lot of labs. They were not willing to do it. They did not have the facility.
Yeah.
So I had to start treatment anyways.
Yeah, it's available at most of the institutes and
Yes.
big centers only.
And even there, the reports won't be available for next 3-4 days for the final reporting.
Serology, IgM.
IgG,
I did
IgM.
not, I did not go for that.
Okay.
PCR is negative, which it can be, and you have a dendrite. So would you even regard PCR in that case? So I think it's pretty much a clinical diagnosis, and I wouldn't do any test for these.
And conjunctival geographic ulcers have also been previously reported with herpetic infections. So I searched the literature. There were 3-4 case reports which reported conjunctival geographic ulcers.
No doubt. If Cornea can have such
Yes.
conjunctiva still,
Definitely.
because they are mucosa.
Sure.
But there are a lot of other things.
Yeah.
Even bigard extra, what you
Yeah,
could have
that could
caused-
have caused it.
Yeah, congenital.
Right. We're finally in luck.
Let's move to the next person, Dr. Priyanka.
Can you restart the timing? It shows 2 minutes remaining. Timing reset कर दीजिए.
स्लाइड शो कर दीजिए. Good evening everyone. I am Dr. Priyanka Bharti from NMCH Patna. Today I am going to present a case of Tenon's patch graft in perforated corneal ulcer. I have no financial interest. A 25-year-old female patient coming from Patna city presented in our OPD with chief complaint of pain, diminution of vision, redness and photophobia for 2 months. History of present illness, no history of trauma with nail, using multiple medication including steroid, painful diminution of vision, gradually no onset, rapid progression associated with redness and photophobia. No any significant masked medical and surgical history, no history of any addiction. Ocular examination, uncorrected visual acuity was hand movement and IOP was digitally low in the left eye. Anterior segment examination in the left eye, perforated corneal ulcer of size 4 into 5 mm with corneal edema and infiltrate of size 5 into 6.5 mm was present in the left eye. Anterior chamber is shallow, iris is plugging to the wound. Pupil obscure, lenticular opacity is present in the left eye while right eye is within the normal limit. Diagnosis, provisional diagnosis, perforated corneal ulcer with iris plugging. Investigation, routine examination is within the normal limit. Corneal scraping was taken on table in OT and sent for microbiological examination. AIOCMTC done to monitor the wound healing. Treatment, the patient was planned for Tenon's patch graft with conjunctival advancement under LA and started on topical antibiotic, antifungal, cycloplegic, antiglaucoma, oral, antifungal and anti-inflammatory drugs. Surgical management, Tenon's patch was harvested from the inferior quadrant of the bulbar conjunctiva and plugged into the perforation and secured with 10-0 suture. Conjunctival advancement was done and also secured with 10-0 sutures. Post-op advice, the patient was advised to have oral antibiotic, anti-inflammatory and oral antifungal drug and topical antibiotic drop and ointment, topical antifungal, cycloplegic, antiglaucoma drug. On post-op day 1, visual acuity is 5 count, graft in place, suture intact, corneal edema with DM fold present, AC form. Microbiology report, smear broken fungal hyphae seen, culture, no growth is seen. Patient is advised to continue same treatment. On post-op week 1, visual acuity is finger count FC 3 meter, graft in place, corneal edema with DM folds. Post of week 2, visual acuity improves to FC 2 meter, graft in place, corneal edema decreases and frequency of eye drop are reduced per day. Post of month at 1 month, visual acuity is 6/60, graft in place, graft well taken up, 3 sutures are removed. At post of 3 months, visual acuity improves to 6/60, graft well taken up, cornea is clear, and the patient is continued antibiotic drop and ointment and carboxymethyl cellulose. And patient is reviewed 2 weekly and it is still under follow-up. AIOCMTC done at 2 months so the Tenon's patch graft get incorporated into the corneal stroma and the conjunctiva get intermingled with the corneal epithelium. This is the timeline showing follow-up of serial number of photographs which is showing the cornea is getting clear day by day and the vision is improving. Discussion, Tenon's patch grafting of a paracentral perforation gives good refractive outcome, minimizing astigmatism, acceptable rate of endothelial loss, addition of conjunctival flap, rapid replacement of lost stromal tissue, complete filling of the perforation, vascular remodeling within the conjunctival flap, correlate with the course of wound healing, formation of conjunctival feeder vessel within 4 weeks, spontaneous regression by 4 months. Patient young age increase the likelihood of rapid vascularization and healing. Combining Tenon's patch grafting with a conjunctival flap resulted in much faster healing as compared to Tenon's patch graft alone. Conclusion, it is an effective, accessible and affordable method. Restore tectonic integrity, preserving clarity of the visual axis, reducing surgically induced astigmatism, reducing the need for keratoplasty, beneficial where there is limited access to eye banking, add healing with favorable post-operative refractive outcome. Thank you.
So thank you, Priyanka. That was a nicely managed case. Sir, any questions you want to ask?
No, it's using Tenon's is an approved way of managing a tectonic support, giving a tectonic support for perforations. So I think what she did is right.
Okay. Ma'am, any experience of using Tenon grafts in infected cases? Because personally, I have also done Tenon graft, but most of them were either sterile melts or peripheral corneal perforations, either traumatic or mostly sterile melt patients. So not in infective cases have I tried myself Tenon patch.
Yeah, in acute infections, of course, it's not a great idea if you have a perforation, but we have used it. So one of our fellows looking at, we have about all the cases that we've done, maybe about 12, 14 patients in which in acute infections we had done a patch, probably because of
lack of tissues.
Yeah, not lack of tissue, probably because we thought we could
Some
do
smaller
it.
perforation.
It's a smaller perforation,
Okay.
and we can handle that with a Tiemann patch graft rather
Okay.
than multi-layered AMG and it wouldn't be amenable to glue.
Okay.
And it seemed to be doing well.
Because as such, suturing the graft is a little different from suturing a corneal tissue.
Yes.
So suturing in the presence of infiltrate and surrounding
Yes.
sloughing
So
is...
most of the time with TPG, we don't suture, or we suture with onlays. So we
Onlays,
don't place
okay.
it into the corneal stroma. So the onlay has to be beyond the infiltrates. You can't use it for if there's a lot of infectious material, where most of the infectious material infiltrate is gone, and you
Yes.
have most of thinning and a perforation, and it's still infection though. So those would be an appropriate indication for TPG, not an active infection where you have a large exudate. By no means can you, or large infiltrate. I don't think this is the appropriate strategy. So her case was appropriate in that
Yes.
way.
Thank you, Priyanka. So we'll move on to the next presentation, Dr. Ankita Sharma.
I think this is the second last. Yeah, we should have questions.
Good afternoon, everyone. Today I will be presenting Blau syndrome with bilateral band-shaped keratopathy and bilateral uveitic cataract, a case report. I have no conflicts of interest to disclose. Coming to the case, a 5-year-old male child presented to the pediatrics OPD of AIIMS Patna with erythematous skin lesions all over the body since 6 months of age. Fever, knee and wrist joint pain were present on and off for the past 1 year. Diminution of vision was there in both eyes, which was gradually progressive and painless. Redness in both eyes was intermittently associated with pain. There was no significant family history. The general examination showed dry scaly skin, malar erythema, and swelling over the bilateral wrist, ankle, and knee joints. He was advised a rheumatology profile and was referred to the ophthalmology OPD. The visual acuity by Cardiffs was 6/30 in both eyes. The digital tension was normal in both eyes. On anterior segment examination, there was bilateral band-shaped keratopathy, right more than left. In the anterior chamber, the cells were 2+ with no flare. There was total posterior synecdoche, festoon non-dilating pupils with cataractous lens in both the eyes. The fundus examination, the media was hazy. So USG B scan of both eyes revealed posterior capsule to be intact, low to medium reflectivity echo suggestive of bilateral vitritis, retina choroid sclera complex to be within normal limits, and optic nerve head to be within normal limits. All these findings helped us to zero in on a diagnosis of Blau syndrome with bilateral band-shaped keratopathy with bilateral complicated cataract. The following investigations were ordered. ANA profile was negative. The patient was started from pediatric rheumatology side on injection methylprednisolone 400 microgram, injection methotrexate 0.7 ml subcutaneous weekly, oral prednisolone acetate 25 milligrams OD after food, tablet folic acid 5 microgram once a week, and tablet naproxen. From the ophthalmology side, combination eye drops moxifloxacin plus prednisolone acetate 4 times per day was started. Atropine drops were started thrice a day. Carboxymethyl cellulose drops 6 times per day, and HPMC gel 0.3% at bedtime. Sequential EDTA chelation right eye followed by left eye was carried out along with bandage contact lens application. This was the follow-up after EDTA chelation. Subsequently, the patient underwent phacoaspiration plus posterior curvilinear capsulorhexis plus PCL implantation under general anesthesia under explained GVP under steroid cover. Both eyes were done at 1 month interval. These were the steps. The follow-up after 1 month showed that visual acuity in the right eye was 6/24 and in the left eye it was 6/9. So Blau syndrome, it was described by E.B. Blau in 1985 as a familial granulomatous disease of the skin, joints and the eyes. About 220 Blau syndrome cases with confirmed NOD2 mutation have been reported. The prevalence is less than 1 in a million. It is a monogenic disease resulting from mutations in pattern recognition receptor NOD2. There is a triad of dermatitis, arthritis, and uveitis. The skin involvement is generally a erythematous maculopapular rash, but can be a dry scaly rash, as was in our case. The arthritis, it is of non-destructive type and boggy in nature. The uveitis may start insidiously as a posterior uveitis, but may later on turn into a pan-uveitis. Systemic and topical steroids with disease-modifying agents such as methotrexate are the mainstay of therapy, and biologics are useful if there is severe eye disease. These were the ocular manifestations. The star-marked one were, in our case, bilateral granulomatous anterior uveitis, band-shaped keratopathy, posterior synecdoche, anterior chamber cells, complicated cataract, and pan-uveitis. So Blau syndrome, it remains an underreported entity in India, And also it can inappropriately suggest diagnosis of juvenile idiopathic arthritis or tubercular uveitis. So in very young children, we need to consider this diagnosis. We need to elicit a proper family history. Genetic counseling needs to be done. Prompt management is pertinent to avoid morbidity, and interdepartmental collaborative efforts are the mainstay for a good outcome, as was seen in the index case. Thank you so much. So the eye should be quiescent for at least 3 months before we can go for a cataract surgery, because if then there can be extensive post-op inflammation if we don't take this aspect into account.
And role of IOLs, which type of IOL you will prefer?
Sir, in this case, generally we should not go for any kind of acrylic IOLs or silicone IOLs. These are generally should not be advised. We should go for hydrophobic. Yes.
Will you go for hydrophobic or hydrophilic ones?
Hydrophobic ones, not hydrophilic ones.
What immunosuppression is going on for the child?
Ma'am, methotrexate.
That's the most important, not to stop them.
Yes, ma'am.
I
Thank you
think
so much.
we can move on. So, okay. Okay, so I'd like to invite the next speaker, Dr. Rakiko Sumesh, and she'll be presenting on acute severe donor-related multi-drug resistant Klebsiella keratitis after LK.
Actually, he is also managing from there. Good afternoon. I am presenting a very interesting yet challenging case of donor-related multi-drug resistant Klebsiella causing interface keratitis and lamellar keratoplasty. So this is a case of 17-year-old boy who was diagnosed with keratoconus left more than right eye. And his BCVA was 6.9 in the right eye and 4/60 in left eye, which was not improving due to presence of apical scarring. And thinnest pachymetry in right eye was 438 and left eye was 321 microns. So we planned C3R in the right eye and deep anterior lamellar keratoplasty in the left eye. So the surgery went uneventful under peribulbar anesthesia, and we used donor tissue from 65-year-old. And it was retrieved from hospital, and in situ corneal excision was there, stored in cortisol, and donor death to transplantation time was 5 days. So on day 1, post-operative day 1, patient had mild pain, conjunctival mucopurulent discharge, and ciliary congestion. And we could see multiple yellow-white deposits at graft-host interface, and which was further confirmed on ASOCT. And keeping both bacterial and fungal in mind, we started fortified antibiotics and antifungals, and we planned for the regraft as well as collection of samples for microbiological examination on the same day. So since the exudates were extending beyond the graft host junction and we didn't have very good quality of cornea with us, so we planned for penetrating keratoplasty, not going for regraft, lamellar graft, and we oversized the graft by 0.5 millimeter. And all samples removed lamellar graft, host, descemet membrane, corneal scrapings taken from the stromal blood, as well as the residual corneoscleral rim with storage media, all were sent for microbiological examination. So on very next post-operative day, we found that infiltrate and stromal infiltrate as well as hypopion reappeared again, and they were kept on progressing. And smear showed gram-negative bacilli, culture and sensitivity reports were still awaited. So we started topical vancomycin, ceftazidime, as well as oral corticosteroids. So after 48 hours, all sample which were sent for the culture revealed Klebsiella pneumoniae, and the Klebsiella was also positive in donor corneoscleral rim, so it confirmed the donor-host transmission of infection. Unfortunate part was this organism was multi-drug resistant and only sensitive to colistin. So we started colistin drops early and along with oral and topical steroids. So on the next day, after 48 hours, we got a very good quality optical tissue with 3022 cells per cubic millimeter. So we again posted the patient for a keratoplasty with the anterior chamber wash with the colistin. And now patient has completed around 4 to 5 months. We continued colistin for 6 weeks and then stopped. And now he has no recurrence of any infection and attained 6/9 vision with minus 1.5 diopter cylinders. So post keratoplasty, microbial keratitis is not an uncommon entity. Its incidence is around 6.5% to 10.5%. And most common organism isolated are fungal, basically candida, followed by gram-negative and gram-positive organisms. And most of them are related to donor. So the common risk factors for having this donor host contamination is multiple warming cycles. In lamellar keratoplasty is common because there is a potential space for growth of microorganism, and long-term hospitalization, and the patients who were treated with multiple antibiotics, who have ICU stay for more than 4 days, and death caused by the sepsis. And in DALC, again, it gives a good space for the growth of organism, and there is organism are actually protected from the direct exposure to antibiotics. So these cases are really challenging to treat, and there are 4 cases reported of Klebsiella pneumoniae in day 1, and all showed that all had a very acute onset either on day 1 or 2, and all were managed with the immediate intervention, surgical intervention in form of lamellar keratoplasty or penetrating keratoplasty with recognition of organism, and sensitivity of drugs are very important to deal with these organisms. So targeted antimicrobial therapy and consideration of early surgical intervention are required to treat these cases of infectious lamellar keratoplasty, particularly after DALC. Thank you.
Thank you, ma'am. That was a well-managed, complicated case with excellent outcomes. And obviously, infection post-LKs are difficult to manage because the interface is not, the penetration of the drug is not so good. Ma'am, anything you would like to share?
Should we not go on to the last case?
Yes.
We'll see the next session people coming in.
So please, Dr. Surbhi Shalini, will like to have you here for your presentation on double anterior chamber, complications of DALC.
But very interesting and very well managed case, Jackie. Yeah, it's a nightmare otherwise. Yeah.
Good afternoon, everyone. My name is Dr. Surbhi Shalini from PMCH. I am here presenting a case of double anterior chamber complication of deep anterior lamellar keratoplasty, DALC. There is no financial gain. Here's a case of 49-year-old female post-DALC patient presented in the IOPD on day 5 post-operatively with complaints of pain and watering in left eye for 2 days. Patient was apparently well after DALC procedure. Then 2 days back, she started developing pain and watering in her left eye. Patient was diagnosed previously with viral infectious superficial keratitis in the left eye, of which anterior stroma puncture was done twice, and thereafter the patient has undergone DALC procedure a week ago. Post-operatively, she was put on routine antibiotics, antiviral, painkillers, cycloplegics, and IOP loading agents, and other supplements. General examination was within normal limit. On ocular examination, best corrected visual acuity of the affected eye was hand movement. Conjunctiva showed congestion. In the cornea, there was corneal edema. Bullae were present. Graft curti showed 2+. Anterior stroma puncture marks were seen. Anterior chamber was regularly formed. Fundus was unclear due to hazy media. When IOP was done by AT, it showed 40 mm of HJ. Investigation was done in ASOCT, which the double bubble was seen in anterior chamber. Slit line exam showed suture in C2, graft clarity, AC formed, and bullae were present. B scan showed posterior chamber as anechoic. A provisional diagnosis of double anterior chamber post-DAL procedure was made. It was managed by a patient was put on IV fluid mannitol 300 ml IV for 3 days. Air was injected into anterior chamber using 26G cannula. Sterile pad and bandage were applied after antibiotic drops, and eye drop brinzolamide was added twice a day. Patient was followed weekly, and she showed improvement. Best corrected vision turned into 6/60, IOP turned into 20 mm of Hg, and the ASOCT turned out was within normal limit. DALC is a specialized form of keratoplasty performed in disease of anterior corneal stroma, in which pathological corneal stroma is replaced with donor grafts, sparing the corneal endothelium, eliminating endothelial graft rejection, and reduced rate of endothelial cell count. It overcomes multiple complications associated with penetrating keratoplasty, which being an open glove surgery, it may cause expulsive hemorrhage and end off, etc. The indication for DALC keratoconus, hereditary dystrophy, ocular surface disease, infectious diseases. Here we are discussing complication of DALC. As an intraoperative complication is Descemet membrane break, which can happen during trephination, during stromal layer injection, during manual layer by layer dissection, or during suturing. Its management depends on the size and the location and the stage at which the perforation happens. If it happens during initial stage, and if it is microperforation, it is continued as DALC. Macroperforation in the initial stage of dissection, especially if central, it has to be converted into penetrating keratoplasty. If perforation occurs during suture technique, it can be managed by a air bubble in anterior chamber. Here the case was double anterior chamber. It is encountered immediately following DALC surgery if there is a microperforation. It can be noticed on slit line examination with a distinct space between donor stroma and host DM. Very small peripheral double chamber may resolve spontaneously, but a large chamber requires air or perfluoroprofane gas injection. Other complications are raised in intraocular pressure and graft rejection, also suture-related complication. In conclusion, DALC is an alternative to penetrating keratoplasty for anterior corneal stroma disease, has proven to be better time and again. It has become an automatic choice for disease for anterior cornea requiring keratoplasty. However, it is not without complication, but the complication can be managed if they were identified and managed early. Thank you.
Thank you very much, Surbhi. That was excellent and well-managed case. With that, we conclude this session. I'd like to thank all the speakers for the really wonderful, very challenging cases. And thanks, Pranati. Thanks to the organizers for having us here.
Thank you.